I have been seeing patients with all types of headaches over the past 5 years, and the number one thing that my patients tell me is that they wish they knew about the occipital nerve block earlier because it was very life-changing. And so in this video, I will be telling you more about the occipital nerve block, what the indications for it are, and what the protocol looks like. For those who don't know me, my name is Dr. Sater. I am a double-boarded neurologist and interventional pain doctor. The occipital nerve itself is essentially this nerve that you see in yellow right here. It comes from the cervical spine, so it originates around C2, C3, and then it goes through the muscles of the neck, and then it goes toward the back of the head. And you have two or three major branches. You have what we call the greater occipital nerve, that's the one right here. And then you have the lesser nerve, which goes more toward the temple and the ear. And then you have the third occipital nerve, which is more in the middle, midline. But usually when people talk about the occipital nerve, we're referring to the greater occipital nerve that you see in yellow. So this guy right here. Occipital nerve blocks can be very useful for different types of headaches. First and foremost, they are the treatment of choice for occipital neuralgia. So that's when you have pain radiating and shooting essentially in the distribution of the occipital nerve. But that's not the only indication. It's also indicated in migraines. It is indicated in cervicogenic headaches coming from the neck. It's indicated in cluster headaches and other autonomic cephalalgias. And the idea behind it is essentially that we are decreasing the inflammation around the nerve. So when we go in with a needle and we inject local anesthetic like lidocaine and a steroid, we're decreasing the inflammation around the nerve, and that is supposed to be the mechanism for why it helps. Now, a very important thing to keep in mind right here is that there is really two major but vastly different approaches to doing an occipital nerve block. So the way that neurologists are usually taught to do an occipital nerve block is at the scalp level. So that is essentially at this level right here, and that is targeting the distal part of the nerve. However, based on cadaveric studies, what they found is that the nerve itself can be located anywhere between 1.5 centimeters from the occipital protuberance all the way through like 7 or 8 centimeters away from it. So by doing it in that fashion, blind under the scalp, a lot of times providers are really missing the nerve and not giving you the full benefit. A much better way to do it is actually in the cervical spine where it originates. So like I said before, it originates from the C2, C3 region, and it is very reliably found between two muscles called the semispinalis and the inferior oblique. So by using ultrasound guidance, we can actually find the nerve, we can see the nerve itself, we can see the structures around it, and we can inject a much smaller volume of medication because we can see the nerve, as opposed to doing a field block in this region because we don't know where it is. And so it's much more reliable, significantly more effective. However, it needs to be done by someone who is well trained in ultrasound. And that tends not to be a neurologist because neurology training does not usually involve ultrasound use. That is more often taught in anesthesia pain fellowships. Now, I'm privileged in the sense that I've had both trainings because I did neurology for residency and then I did interventional pain for fellowship. And so I'm able to make that link between the two. But usually you're going to find a split. You have the neurologists who know how to only do the distal occipital nerve block under the scalp, but they are the ones often seeing the patients who have these conditions. But then you also have the anesthesiologists or other pain physicians who know how to do the procedure the proper way, but they are not necessarily going to get the patient referrals because if you have a headache, you're referred to a neurologist, you're not referred to an anesthesiologist. So my recommendation to you is to ask and to raise awareness when you're discussing this issue with your providers and make sure that you get the correct procedure because it can be very life-changing. And then it doesn't have to be done on its own. A lot of times it can be combined in a staggered fashion with other procedures like Botox injections, for example. And that combo can bring your headaches all the way down to essentially a zero. All right, I hope you found this useful. I'll try at some point to take a video of this procedure as I'm doing it on a patient with the ultrasound so that you can get a better idea of how it's done. But in the meantime, check out the video that I made last week on tension headaches and why I think that it's a misdiagnosis. And don't forget to like and subscribe.